All right. So for those that, again, that don't know me, thank you. All of my nursing background was emergency, and my last job was here. I worked here for about 3 years, and I just left last year when I graduated from UVA with my NP degree and got a job over at Martha's with their hospitalist group, so with their admitting service. Over the last year, what I've noticed is that the nursing errors that happen are because that you just don't know, and that you've lost a little bit of that knowledge from the patho standpoint. And so one of the biggest things I see is with DKA and insulin drips, and the hope is that when patients are started on these things in the emergency department, that they get upstairs and they ultimately transition off upstairs. But the longer that patients are waiting now in the ER, and we're having big borders in the ER, we're seeing that here. And so what happens is that the protocol gets aborted by the nurse just because they don't know what we're looking at and stuff. So that's how I got involved with this. So a little bit about diabetes. Pre-diabetes is an A1C of 5.7 to 6.4, and we'll talk more about what an A1C is a little bit later. A fasting glucose of 100 to 125, or a random glucose of 140 to 199. 86 million Americans have prediabetes, and 9 out of 10 of those are unaware that they have it. So that means there's 77.4 million Americans walking around with prediabetes and don't know it. Prediabetes it just puts you at a higher risk, obviously, for diabetes, and 15 to 30% of those people will develop type 2 diabetes. They can be educated and found out, and they can do lifestyle changes, so weight loss, exercise, diet, stuff like that, but a lot of them just don't know. In 1980, there were 5.6 million Americans with diabetes, and in 2011, there were 20.9 million Americans with diabetes, so a huge jump in the population and the prevalence of that. More than 11 million ER visits yearly involving diabetes, and if you have diabetes, you have a 50% greater chance of coming to the emergency department for some reason. More than 170,000 diabetics yearly will visit the ER with some kind of crisis, so DKA or HHS or HHNK. In 2009, more than 140,000 discharges from DKA with an average length of stay of 3.4 days, compared to 1988 when there was only 80,000, but their length of stay was longer. So that shows us that we're treating it better and we're getting patients out of the hospital quicker, but we're having a much larger number of patients that we're seeing with this. In 2009, there was documented over 2,000 deaths related to DKA or this HHS or HHNK. Diabetes remains the 7th leading cause of death in the U.S. In 2010, over 300,000 death certificates listed diabetes as one of the underlying causes for death. And in 2012, over $400 billion were spent diagnosing and medical costs directly associated. I don't necessarily have to be on the camera. The International Diabetes Federation is a worldwide organization that involves over 200 diabetic associations and is involved in more than 160 countries. They predict that 1 in 10 people worldwide will have diabetes by 2035, that every 6 seconds someone dies from diabetes, and 175 million people are currently undiagnosed. So this is just a map that they have, a little bit outdated, 2013, but just kind of shows in relations to where people are. Not sure what's happening here. I was for sure that the U.S. would be at the top of the list, but quite a few people living with diabetes. So we all know that diabetes has quite a few complications. In 2011, if you were over 35 years old and had diabetes, they saw 5 million had coronary artery disease, 3.7 million had other heart disease like heart failure, and 2.1 million had diagnosed strokes. In 2008, almost 50,000 Americans began dialysis for end-stage renal disease, and compared to only about 2,600 in 1980. So a huge climb. In 2011, 4 million Americans with diabetes diagnosed with some type of visual impairment. And then from 1988 to 2009, the number of discharges for amputations increased by 24%. So what is diabetes? A metabolic disorder in which there's an abnormal production or an abnormal use in the way that our body uses insulin, causing an elevated level of glucose. A little bit of anatomy. We have our stomach, and this would be our pancreas. So we know that our pancreas secretes digestive enzymes. So we know when we take care of patients that have pancreatitis, we keep them NPO. So we don't stimulate the pancreas to make more digestive enzymes, we let it rest. The pancreas also secretes hormones, insulin and glucagon, in relations to the blood sugar that it calculates within the blood. So two very important roles. These little areas of the pancreas, so they have the two big cells that we're looking at are going to be beta cells and alpha cells. Beta cells produce insulin and alpha cells produce glucagon. So insulin from the beta cells increase number of glucose. It secretes the insulin. On every cell membrane, we have insulin receptors. And so we know that if someone's potassium is elevated, we give them insulin. It drives the potassium into the cell with the insulin. Same thing with glucose. Glucose can't get into the cell unless an insulin activates the insulin receptor. So without insulin, these receptors are shut off and glucose can't get into the cell. Why does glucose need to get into the cell? Because the cell uses it for ATP or for energy. So everything that our cells do needs energy, and we get most of that from glucose. Again, just what do we need cellular energy for? Again, to move substances across the membrane of the cells, to move, so to get up and walk around, to have muscle contractions, or to do some of the breakdown of proteins and carbohydrates. Glucagon, which we know from the injection that we give in the emergency department as well. So I always tell people a little bit of a tongue twister on words. So glycogen is a carbohydrate that's found within the liver. Glucagon is excreted through the pancreas from those alpha cells, and so, or injected, whichever way. And that breaks down the glycogen that's found in the liver and turns it into glucose. So this is important during fasting times or when your sugar bottoms out, stuff like that. Your body can produce its own glucose by excreting glucagon. So bottom line, to keep it simple, beta cells secrete insulin in response to high blood sugars. Your pancreas with the alpha cells secretes glucagon for low glucose levels, and the ultimate goal to keep a normal blood sugar going. But when that doesn't happen, we either get a hyper or a hypoglycemic state. So a little bit more about what it does to and how diabetes affects the body. So we know that patients come in with neuropathies and different organ system failures. So if this is a nerve, you have blood vessels that wrap around each nerve. And so with diabetes and with high blood sugars, your vessels get damaged, which ultimately leads as well to nerve damage. And so you end up with a nerve that is either non-functional or dysfunctional. So a lot of patients will have gastroparesis, so the signals that go through these nerves are either delayed or impaired in some way, and so the stomach doesn't empty or it doesn't recognize that you're full, so you get a lot of nausea, neuropathies, retinopathies in your eyes, kidney disease, and then obviously vessel disease. Again, just showing a normal nerve over here sends signals, but it's going to be delayed coming through here because your nerves are damaged through here from the diabetes. So again, pain, dysfunction, or patients ultimately end up with numbness and tingling. So the hemoglobin A1C is a test that's used both to diagnose and to monitor the treatment for diabetes. Your hemoglobins, we know, live for about 3 months before they die off. Glucose is naturally attracted to the hemoglobin, and the bond is irreversible. So similar to the glucose on the nerves, the glucose sticks to your hemoglobins. It's calculated as a percent of how much of your hemoglobin is covered in glucose. So if you have one spiked day, it's not really going to make that big of a difference. We're looking at the average when they look at that blood sample to see how many or how much glucose is stuck to your hemoglobin cells. The higher the amount of glucose is stuck to the majority of the cells, the higher your blood sugar's been over the last couple months. And someone down the road has come up with a number. So if your A1C is 4, your average blood sugar is about 65. As the higher your A1C number goes, the higher your average blood sugar goes. So you'll have highs and lows on both sides of those. So what we want to see is for patients, obviously, to have a normal value and not have diabetes. If your A1C, again, is that 5.7 to 6.4, you're in the pre-diabetes category, and your physician will talk to you about kind of lifestyle changes, whatnot. Anything above 6.4 or 6.5 is a category for diabetes, so then you ultimately get put on treatment. And then when we see patients in the hospital, what we want to see is a hemoglobin less than 7 on patients that are being treated with diabetes. If it's greater than 7, then before, not necessarily for you all, but for us, when we discharge them, we try and put them on something more to cover them better. High insulins and weight. So insulin converts glucose into fat storage, so adipose tissue. Insulin inhibits the breakdown of adipose tissue to generate energy. So people say, why would we not want that? Or why would we want that? And a lot of these like crazy diet routines out there that people have, that you lose like 50 pounds in 2 weeks, this is a process that they tried to target. And so it puts you at a very unhealthy state, and that's why you end up putting much more weight back on pretty quickly. But in type 2 diabetes or pre-diabetes, your pancreas attempts to compensate for high glucose levels. So it produces more and more insulin, which in turn promotes fat storage and a lack of breakdown of that fat tissue. So in other words, high insulin will promote fat storage, thus weight gain. With insulin resistance, you can have insulin resistance and not be diabetic. It's a similar concept. Your pancreas produces more insulin. It's not effective in lowering your blood sugar, and will cause you to gain weight and or have a difficulty losing weight. So types of diabetes: type 1, type 2, and gestational. Type 1, mainly seen in the onset in pediatrics, an autoimmune disorder where the body actually attacks the beta cells within the pancreas. So they have little to no insulin production. Usually, again, at onset in childhood, and then approximately 1.25 million children and adults have type 1 diabetes. Type 2 diabetes is a dysfunction of the beta cells, leading to an inadequate production of insulin. Insulin resistance happens down at the peripheral cells, leading to an inadequate use of insulin. Onset is usually in adults. Unfortunately, we see it more and more these days in the younger population. And it is shown to be linked with this metabolic syndrome as well. So we know metabolic from the Who's Well thing that they check for. 3 out of 5. So overweight, high triglycerides, low HDLs, hypertension, or elevated fasting blood sugar. 3 out of 5 of those, you're diagnosed with metabolic syndrome, and your risk for diabetes is greatly increased. In 2008, again, over 5,000 children less than the age of 20 were diagnosed with type 2 diabetes. So very unfortunate. Gestational diabetes is the mother's abnormal response to the hormonal changes, and affects insulin production and puts them in more of an insulin resistant type state. So there's an increased risk for the mother and child to become and to be diabetic. So diabetic emergencies that we see within the emergency department, in the hospital, diabetic ketoacidosis, and then this hyperosmolar hyperglycemic state. DKA, most often we see it in type 1, but it doesn't mean you can't see it in type 2. It's due to the lack of lack of insulin in the body, compensated by the following. So when we have a lack of insulin, we get breakdown of fat for calories. We get a breakdown of proteins and amino acids for energy. Thus, you see a little bit of weight loss. You see some thirst. Also, high glucose in the blood. So the intracellular, so if you have your vessel and you have your cells, your vessel within your blood, your sugar will be really high, but there's no receptors turned on to get glucose within the cell. So the cells think that you're low on blood sugar, and so you're hypoglycemic. So it activates the body to turn on and to destroy and basically break down all that it can to get extra energy. And so we get a lot of this byproducts that make us ultimately acidotic and pretty sick. We also have increased glucagon production because our body, again, thinks that we're low on blood sugar. So the glucagon production within the pancreas just adds to a higher blood sugar. So you have your liver making glucose for yourself. That just further breaks down more fat, further breaks down more of these proteins and amino acids, ultimately leading to this ketone release within the blood. And so that's where we get the ketones in the urine. We get a big kind of acidotic state. We also get this osmotic diuresis, so they get a lot of urination as well. The osmotic diuresis is similar to the effects that we see with mannitol, and increased substances within the blood from vigorous breakdown of fats, amino acids, and proteins in the body, just as an effort to increase intracellular glucose. This causes an increased pressure within the tubules. So when we drink, I tell people, when we drink a big glass of water, our vessels stretch because we have more intravascular fluid. The tubules within your kidneys stretch, and your kidneys think, "Ooh, we got to get rid of some of this pressure." So they makes more urine, makes us pee more. The same thing when we have all this breakdown of different tissues and cells, we get a big release of just byproducts within our bloodstream, stretches our vessels, stretches those tubules, and the tubules think, "Whew," they don't recognize it as debris or breakdown. They recognize it as just too much volume, and so they have this mass diuresis. So we have this kind of mass urination, and then you spill glucose over in it, obviously. You get changes in your vision because of the volume depletion, and ultimately you end up with this intracellular dehydration and the intracellular starvation. So nothing is getting into the cells. Everything's kind of doing its own thing in the blood. If left untreated, you end up with ketones in the blood. You end up with a metabolic acidosis, lactic acidosis from everything that's being broken down. Your blood sugar obviously goes up, this ketosis state, dehydration, and a lot of electrolyte imbalances. HHS, or this hyperosmolar kind of state, is got 4 specific features, a little bit different from DKA in the sense that they both have a high blood sugar, but in HHS we have an absence of this ketone production. So there's enough insulin that's being made within the body to keep some of this breakdown at bay. And so we don't get to the point where we're making ketones in response to the breakdown. So this is pretty common feature. You get this profound dehydration, even much more so than the DKA. And then this one is pretty markedly known by the neurologic deficits that you have. So we can have patients that come in with DKA that are very altered because they're super acidotic, and their state of DKA is pretty severe. But we can also have patients that come in with DKA and they're sitting there talking to us, they just don't feel good, but they're awake and oriented patients with HHS are going to be disoriented, and they're also going to have pretty high levels of glucose. So DKA patients are usually in the upper 100s, so usually around 600 or less. And then our patients with HHS are going to be way over 1,000. So the patients that come in with 1,500 or 2,000 blood sugars, that's going to be this patient, and they're going to be altered from the start. And so again, just very similar, we just don't have that ketone production. Causes of DKA and HHS are all the same. So sometimes it's the first time that they're being diagnosed with diabetes. Can be stress related from a car accident or from a stroke or MI. Alcohol use or abuse as well. Infection we see pretty commonly as well. We know that infections put us at kind of a insulin resistant type state, so we use a little bit more insulin than we're used to, and so we have a tendency to run higher, which can put us into these states. Trauma as well, and then probably a really big one would be non-compliance, whether that's intentional or not. I was telling them yesterday, this is probably one of the common ones that we see over at Martha's from our elderly population that uses insulin. They either get confused, they don't know how to use their insulin pump, they forget to take their insulin, or it's a cost thing that they can't afford it. So signs and symptoms of the two are pretty similar. They both are going to get dehydrated, weak. You're going to have thirst and a lot of urination. The altered mental status, again, is the key one for the HHS. You can get it again with the DKA, but it's going to be in a severe state of DKA. You can get over here with the DKA the weight loss just from all of the breakdown. Usually not in the acute state, it's more of kind of an ongoing thing. Visual impairments, because they're so acidotic, their respiratory system kicks in to try and overcompensate for that, so you get some abnormal breathing and then the fruity breath, which I have never been able to identify. But some people are experts at it. So this is just a chart that just says all that I just said. So insulin deficiency will lead from a DKA standpoint. You get all of these processes, which are just those breakdown processes we talked about. You get this ketones in your blood, you become acidotic, you are in this DKA type state, left untreated can ultimately lead to death. Same with the HHS. You kind of get this hyperglycemic state, you get glucose in your urine, this really profound diuresis. You get this salt and water depletion, ultimately leading to some confusion, and then if left untreated, death. So some of the lab values that we monitor when we're looking at the two, or you have someone that comes in that you're concerned for some kind of diabetic crisis. Obviously your glucose, again, the hallmark to HHNK or HHS would be this super elevated glucose. Your DKA, I mean, we see patients that come in all the time with diabetes. They're not in any kind of process of acidosis and their blood sugar is 400. So you don't have to have, just because your blood sugar is up, obviously you don't have to be in one of these states, and your sugar doesn't have to be super high for you to be in DKA either. For DKA, we see a lot of acidosis, and so your pH is going to be much lower. The HHS, not so much, but it doesn't mean that we don't see it, especially if it's left untreated. And so a lot of times these HHS patients have been running high for a long time, just something that's pushed them over the edge. And so we can see acidosis, but it's more commonly in the DKA. Your bicarb, because of the acidosis, is really low with the DKA, not so much with the HHS, just because that acidosis state doesn't always exist. Ketones in the urine and in the blood for DKA, not so much in the HHS. So here we check it for ketones in the urine. Over at Martha's, we check them in the blood as well. So I didn't ever see us do it here in the blood as much. So that's just the acetone test. The serum osmolality, so that's just kind of the fluid shifts within your blood, can be variable with DKA. You get a lot of diuresis, but definitely much more so with the HHS, so that's pretty hallmark. And then an anion gap, we see from the acidosis with DKA, not always as much with the HHS. And then the alteration again with DKA, mild DKA or not so much DKA, not going to see much mentation change, but that HHS you will. So the anion gap is a calculation. It comes on your chemistries, but if you wanted to calculate it yourself for some reason, there's a calculation for you. It's just your positive ions within your chemistries minus your negatives, and basically what you're looking for is a measurement of the unmeasured ions that are in your blood. And so those would be lactic acid, ketones. So when you have an elevated anion gap, that would identify the presence of these unmeasured anions. So when you have a high anion gap, you can argue that you're in an acidotic type state. So the treatment of the two is very, very similar. Hydration is huge, insulin, obviously, and then correction of electrolytes, and then for DKA, and it could be for the HHS, a correction of that acidosis. So fluid replacement is, so this is, again, specifically for adults. So pediatrics, and Donna will go over that later, is a little bit different in the way that we manage and treat. But for adults, fluids are extremely important. We can give patients, you know, I've seen patients get 8-9 liters of fluid for these because of their just severe dehydration and their acidotic state. So lots and lots of fluid. So we want to try and determine what their hydration status is, and usually they get several liters of normal saline. If you're concerned that their sodium is low, we know we don't want to overcorrect that too quickly, so we can alter some of the percents of saline solutions that we give, but they're still going to get quite a bit of fluid. Obviously, if they're shocky, then we're going to give them pressors if we can't get them up with fluids. And then ultimately, once the sugar with the insulin drops to a certain level, usually sometime around 200 to 250, we put D5 in the solution. So the key here is when it comes to insulin, insulin is the key driver to a lot of this. And so we don't turn off the insulin drip until the acidotic state, your electrolytes have replaced, your anion gap is closed, and your sugar's back to a normal sign. And that's where I see the error happen on the nursing side, is we'll come back to check on a patient, and the patient's been off the drip for 4 hours because the blood sugar dropped to 200 and they turned it off. But they're still in this acidotic state, they're still in DKA, or they're still in this HHS state. And so that's where I see the lack or those errors happen. So big key point. So insulin, and Angela will go over the protocol here on how much insulin the bolus is, and then you end up putting patients on a drip. And you monitor labs pretty frequently, so at least every 2 to 4 hours, you're looking at their electrolytes and their anion gap are the big key kind of things. Mainly the potassium, because we know insulin will drive the potassium into the cell, and so we have to watch for hypokalemia. Again, if the insulin drops 200 to 250, we don't stop the insulin drip. We just put dextrose in the solution and give them sugar back. The insulin will help to correct that acidosis. Your goals for your sugars are a little bit different for each, and each hospital is a little bit different. But the HHS we treat until we see some mental status changes or back to baseline. Again, that potassium replacement, you have to watch if your potassium is already low in the beginning, you're going to want to give potassium to them in the beginning, because that bolus of insulin that you gave is just going to drive their potassium even further, and we don't want to code anybody. If you're, once you're on the drips and your potassium starts to run in a little bit of a kind of below 5 really range, then we want to start adding potassium to the fluids that we're given. So we can put it in our big liter bag of fluid, 20 to 40 milliequivalents. But if your potassium is less than 4 or is really kind of driving down quickly, sometimes we just have to give them the K riders and and be done with it. Sometimes they needed a little bit faster replacement than what we're given in that fluid. But sometimes the fluids, even at 250 an hour, it's still going to take 4 hours for that liter bag to go in. So they may need more than just 20 milliequivalents in 4 hours. You know, they may need 40 within the next little bit. So monitor their renal function. So we don't want someone that has no renal function. We don't want to overcorrect their potassium, because then we'll be looking at dialysis. So we just, and then something I had no idea about, and I didn't mention it yesterday, but until I started working at this, is that we check magnesium.